What I like about Capivasertib personally is when I relook at that data and I look at what the toxicity profile was, and it fits so well with my experience, right? A lot of grade 1 and 2 diarrhea. You have to be able to, anticipate that. You have to have patients be ready, talk to them about diet, and having loperamide on hand, and all the things that you need to do to mitigate that. But it really is true to what they saw in the trial in my clinical practice.
Yeah. I echo that. Month 1, proactively engaging, and I'm so happy we have a clinical pharmacist who really helps manage this, checks in every week at that day 3, 4, helps us figure out where we're doing our blue, but it's like with that proactive management, it goes well. Yeah.
So other than managing diarrhea, what other things do you use prophylactically?
I adopt the cetirizine. I'm doing the once a day 10 milligrams as prophylaxis. I think that even though there's not as much data based on the pathway and class effect, it's we've been doing that regularly. Yeah. Have you been doing the same?
I do. I mean, it's a benign treatment. Many patients are already on medicines like cetirizine, and I have seen patients with rash, and so certainly if it can prevent that, it's again, this quality of life is super important.
Agreed. I think patients that I worry about hyperglycemia, like how you mentioned, how you're preparing them ahead of time. Then kind of if I'm seeing elevated fasting glucose, kind of borderline A1C, kind of the gestaltiness, where we're a little worried, then I'll bring up the idea of doing metformin. Yeah. Typically, I still do that first. I've not jumped right to the SGLT2s. What have you ended up doing?
Very similarly. I mean, I think I do see it as a time, mostly to make sure, honestly, again, I work with an underserved population, want to make sure they're plugged in with the PCP at minimum, in case I need some backup there. Diabetes has changed a lot since I was a resident, so I want some help if I need it. So just plugging patients in with the PCP. Sometimes I start patients on metformin, which low dose metformin is also very well tolerated. So it's very similar.
Are you arranging for home glucometer testing, or is it pretty easy for the people in your area to get the labs, or how have you been handling that?
So that's a good question. It was interesting you mentioned about having a clinical pharmacist. So when I was in university-based practice, we did have better pharmacy support. I think in a private practice clinic, you have less support in that way. And so I rely a lot on nurse practitioners. I think nurse practitioners are incredibly helpful in terms of symptom management. I mean, they are the experts, honestly, in symptom management. And so I think, putting some time into helping to educate your support staff, your nurses and nurse practitioners about what needs to be monitored and what are the symptoms to expect, and some basic strategies goes a long way for the patients and for you as a clinician, right?
Very much agreed.
Yeah.
And it's,
so mostly, again, it's interesting. You would think in a very rural state where patients live far away and have that they would use some of those home monitoring. They're so used to getting their health care by driving to you that even, during COVID, we did very few virtual visits. Everyone thought we would, and we don't, because there's a huge technology barrier. So actually, a lot of people come into clinic. They're more comfortable with that. It's the sort of familiar pattern.